Well, good afternoon, everyone, and I'll say Happy New Year, even though we're 12 days in. I am Susan Ryan, and I'm excited to welcome you to our inaugural series of Building Social Connectedness in a Disconnected World. And I don't know about you, but if ever there was a series that would have more significance, I think it is now. You know, I tell you, we are hardwired as humans to be in relationship, to have that social connectedness. And when the pandemic hit, I think we were challenged in ways we had no idea we would be stretched. And I would tell you that not the least of these were those in long-term care communities that were really stretched. So really excited for this first series to kind of kick us off with really taking a look at what those elder experiences are. So our theme this year is really a challenge to ourselves and a challenge to each one of you. And that is to go beyond better. That we believe this pandemic has created opportunities for all of us to go beyond better, to really embrace new ways of thinking, new ways of being, new ways of doing things. And I know that together we can learn and grow from one another. So a few logistics to get us started. I want to welcome you and encourage you to introduce yourself via the chat feature. If you go down to the bottom of your screen, you'll find the chat box and you can write your name and your organization, where you're coming from. We always like to see how far and wide our participants are calling in from. And that throughout the conversation today, throughout the presentation, if you've got questions for our presenter, I invite you to put those in the Q&A box. We'll spend some time at the end for you to be able to have those questions answered. It's an opportunity where we learn from each other. I want to welcome and give a special shout out to our sponsor for this series, I-N2L, and invite my good friend, Jack York. And Jack, you know, as we were talking just before this thing started, this has been a conversation between us that has gone on for over 10 years. And I think when I talked to Jack about this series and whether I-N2L would be interested in something like this, I can tell you he didn't think twice, but said we're all about this. And so Jack, I'm grateful for your support, and I'm grateful for the work that you have done, especially during the pandemic, in the way I-N2L has served elders and helping them stay connected. Jack?
Yeah, I'll be real brief. And you forgot to bring up the part of the conversation that most of those conversations were with umbrella drinks in Florida, but that we'll save that for another topic. But it was an odd, you know, it's hard to know how to phrase some of what's going on, because it is, in all the tragedy and all the heartbreak of COVID, I think all of a sudden the world has been awoken to the importance of engagement. And that really was always what we were talking about, Susan, was, you know, not just I-N2L, just the whole issue well before COVID of people not being engaged and not being connected. And we never want to imply that technology is the panacea and replaces the personal connection. But last year, all of a sudden, when grandparents couldn't talk to their grandkids and daughters couldn't talk to their moms, it became so relevant, and it's not going back. It is not a novelty anymore to have engagement technology be a part of whatever you're providing, and it's frankly, it's also a positive that there's lots of funding mechanism things available right now. So again, this is looking so forward to Ann's data. We're honored to be a sponsor of this. You'll be seeing me for 2-minute blips for the next 6 weeks. I am going to start highlighting the greenhouse swag that I'll start getting piece by piece. But again, this is such a no-brainer for us to be a part of, and very much look forward to the next 6 weeks. And kudos to you, Susan, for being ahead of the curve and doing something like this, because it's common sense as much as anything else, but it changes lives. And so looking forward to, and we're honored to be a part of it.
Well, thank you once again. You make it possible, and we really appreciate that alignment that we have. I really am excited to introduce our speaker. But before we go there, I'm going to do a couple polls. It's really interesting to kind of know where you sit and how things have worked out for you in this regard. So in your experience, are nursing home residents still expressing concerns about being isolated and lonely? Very often, sometimes, or rarely. You know, this pandemic has gone on and on and on, and it's not letting up. So just curious, especially with the holidays that we've just come through, where things are with your residents. Thank you so much for voting. This is so helpful for us to get put a finger on the pulse to see what's happening out there. All right, Janet, you can stop the polls. Not surprising, this is kind of what my gut would have said. 74% said very often, and 26% said sometimes. There wasn't one that said rarely. So thank you for that, Janet. You want to launch the next poll. One more question for you. So the next poll, there you go. In your view, how useful would it be to train staff in simple techniques to decrease loneliness among residents? So really thinking about, you know, what it would be like to do some education. How helpful do you think that would be? Thank you. I see so many of you have responded already. This is awesome. Thank you for that. All right, Janet, you can stop the poll. How about that, 95%? You agree with me. I certainly believe that education is such an important part of really equipping our staff with strategies and techniques that they can use. So I'm going to get out of the way, but I want to introduce our speaker, and I'm actually going to read her bio. I met Anne years ago, and I can tell you that I have always appreciated her passion for the work that she does. And as I reread her bio before we started, I thought, I need to read this to you so you can fully appreciate who she is. Anne Montgomery is co-director at Altarum's program to improve elder care, where she oversees a portfolio of quality improvement research and policy analysts focused on older adults, particularly with respect to implementing better approaches for coordinating medical care and long-term services and supports. Anne has more than 2 decades of policy experience working on Medicare, Medicaid, and related programs. Prior to Altarum, Anne served as a senior advisor for the U.S. Senate Special Committee on Aging, where she developed hearings and numerous bills and acted as a part of the Affordable Care Act, focused on upgrading quality and tightening accountability in the nursing home sector, expanding options for states to offer home and community-based services in their Medicaid programs, improving geriatric competence across the workforce, and modernizing state background check systems for individuals working in long-term care settings, standardizing assessment processes, eligibility systems, and conflict-free case management protocols in Medicaid. Anne has also served as an analyst for the House Ways and Means Committee, the Government Accountability Office, and the Alliance for Health Policy in Washington, D.C. Anne was an Atlantic Fellow in Public Policy in 2001 to 2002 in London, where she undertook comparative policy analysis of the role of family caregivers in the development of long-term care in the UK and the US. She started her career as a health and science journalist covering the National Institutes of Health and Congress. Ms. Montgomery is a member of the National Academy of Social Insurance, Academy Health, and the American Society on Aging. She has a master's degree from Columbia University and a BA from the University of Virginia, and has taken gerontology coursework at Johns Hopkins University. I just needed to share that because this is a woman that has some incredible experience and insights, but I end where I started, and that she is the woman who is passionate about elders and the care they receive. And it's such a privilege to have you here. So I'm going to turn this over to you for you to share your experiences, your research with Altarum.
All right. Well, thank you so much. Good afternoon, everybody. And I really appreciate that very kind introduction and invitation. Many, many thanks to the Greenhouse Project and to INT2L for the invitation to be here today as we think about what lies ahead and what we're going to try to accomplish. I think it's fair to say that we are at a pivotal point now in the nursing home world, and these are dark and difficult days, and we need to figure out how to rebuild and reshape aspects of the nursing home model of care. But first, I want to focus on the impact of a policy shift that was brought about by COVID-19 and its impact on nursing home residents. And that is, from mid-March through mid-September, visitation of family and friends was essentially not permitted in nursing homes or allowed only under very narrow circumstances. Okay. When COVID-19 hit with absolutely devastating ferocity, and particularly the frail elders living in nursing homes, I was really deeply worried, and so were my colleagues, and I wanted to take action. That is part of my background. And so with my colleagues Sarah Slocum and Christine Stanek, we set out to design and to field a survey that really lifted up nursing home resident voices. And the title of the report is what you see on the top of the screen, and we issued that in October. And interestingly enough, when we designed and fielded the survey, we weren't really sure that it would work because residents are really hard to survey for a number of reasons. And I give thanks to my colleagues at Altarum who had the faith that we could actually pull this off. And here's how we did it. We distributed a public link in July, and we left it up until the end of August. And some of those who helped us distribute the link and get it out to families and nursing home residents are listed here: Ombudsman, Consumer Voice, the Greenhouse Project, Leading Age, AHCA, and others. We really had a lot of help distributing this and getting it to residents. And in the end, we had responses from 36 states for a total of 365 residents who responded. The survey itself had about 30 questions and was designed to focus mainly on social isolation and loneliness, both before and after the pandemic hit. And we also included some questions on safety and quality of care, staffing and advanced care planning. And we lifted up resident voices. They had a great deal to say, which we'll go into in a minute. The backdrop for our survey is that in the summer of 2020, as we know, about 40% of the deaths from COVID-19 that were occurring were among nursing home and assisted living residents, which I believe has not changed dramatically. And because the long-term care residential population represents only about 8% of cases in the US, this very high mortality rate serves to sharply underscore the vulnerability of older adults who are living in congregate settings. The fact that many nursing homes were not prioritized for PPE for both the residents and staff has produced really tragic consequences. And as we've seen, it's very difficult to keep COVID out when the positivity rate in the community is high, and it is exceedingly high in many parts of our country. There are other problems, however, and that is as a proxy for where many nursing homes are with regard to basic infection control, the Government Accountability Office, which is a place I worked for several years, found that prior to the pandemic, the infection control problems were widespread, with 82% of surveyed homes receiving a deficiency citation. So that indicates there's a lot of room for improvement. And therefore, infection control has been at the forefront of what CMS has been emphasizing. And that's great. But not enough thought was given to the consequences of policy decisions to ban family and loved ones from visiting their elders over an extended time period. And that's what we're going to talk about further. Banning family visitors really did not reduce harm. That's the bottom line. Rather, an analysis of excess deaths estimates that for every 2 COVID-19 deaths, an additional death from non-COVID-19 causes occurred as nursing homes struggled and residents succumbed to the impact of severe social isolation. They produced 15% more deaths, according to one analysis, than the usual fatality rate, or about 40,000 additional deaths by this fall. So despite the ban on visitation, the virus has continued to do enormous harm in the long-term care sector, with 471,953 nursing home residents and 402,956 nursing home staff infected with COVID-19. And the mortality rate among residents at 92,373 and 1,268 from COVID-19. That's as of January. That said, it's noteworthy that the Greenhouse Project and some other homes have reported much lower death rates from COVID-19, and that's probably due to good infection control and deployment of PPE, as well as consistent assignment of staff, which is a hallmark of the model. And I think as we look forward to hearing, to thinking about what we can do, we need to hear more analysis of the greenhouse data when it's available, and data from other homes that really are able to keep case and transmission rates very low. So what does the literature say about social isolation? Well, the emphasis on infection control and safety, if it comes at the expense of not thinking carefully about the downstream impacts, can be very detrimental to residents. That's really what it says. We already know from the literature that social isolation, that's physical separation from other people, is associated with an increased risk of dementia. Isolation and loneliness, loneliness is feelings of distress at being alone, are also associated with a higher risk of heart disease, stroke, and a higher prevalence of vascular and neurological diseases. In people living with dementia, some studies have found that loneliness is more prevalent. Verbal agitation, which can manifest in cries and screaming, for example, is more common in residents with cognitive impairment and among those who are lonely. This means that less visitation can be particularly tough on residents with dementia. So now we'll go to the survey, and here are some of our survey findings. Residents reported feeling cooped up, cut off, bored, frustrated, and purposeless. We identified several forms of isolation. Isolation within the nursing home from other residents and parts of the home where group activities and meals are usually hosted. Isolation from family and other loved ones who live in the community. Isolation from the out of doors, even right outside the nursing home, and isolation from the larger community. So I won't read the figures here to you, but I think you'll agree it's not surprising that a very large majority, 76%, reported feelings of loneliness given their degree of social isolation.
And can I just interrupt a moment and ask that you put this in presentation mode to enlarge the slides?
Okay. All right. I'm looking for where that is.
So go back to your presentation, and it should be on the bottom right-hand side. There should be something that would let you do that.
Okay. I'm now not seeing it.
Hit the arrow to go back.
Hit the arrow.
Up there in the top left of your screen to go back to your presentation.
Okay, hang on here. Oh, I'm all lost. All I can see is my screen.
Janet, do you have the slides?
I do. I can pull them up for you.
Okay, that'd be helpful.
Right. And which?
So maybe then Anne will stop sharing, Janet, and you'll advance slides. There we go.
Which slide are you on then?
Okay, let's see.
It was where the survey was down to.
Am I still sharing? Should I stop sharing?
No,
you can stop sharing.
Okay.
And then Janet will share.
All right. Thanks for help with the technology.
Sure, that's what we're here for.
I click through, you just tell me when to stop.
Okay, keep going. Okay, there we go. All right.
This one?
Oh, one back up. There we go. Okay. So this slide speaks to isolation from the larger community, and that has been very common during the pandemic. I don't think that the wider public may realize this, but there really are quite a few residents who are able to access and manage some transportation to and from the home, and who enjoy maintaining links to their communities. For example, some attend church or visit a favorite shop or restaurant, maybe a park. And these connections have withered during the pandemic, and unfortunately, 64% reported that they didn't even leave their rooms. Next slide. So diving in more deeply in these next few slides, this is where it starts getting really sad. In this slide, you can see that residents enjoyed the company of loved ones 3 or 4 times a week. 56% responded this way, but after the visitor ban took effect, the percentage of residents saying they had no visitors soared to 71%. Next slide. And here we see what's happened in residents' lives during the pandemic with regard to going out to the community. While 26% reported that they went out twice a week before COVID-19 hit, after restrictions were imposed, 94% reported that they essentially never leave the nursing homes. And as I indicated, I think many Americans assume that nursing home residents generally never go out anyway, but our survey really found that that was not the case. Next slide, please. In terms of the simple pleasure of going outside when it is not raining and not too cold or too hot, this is a routine that most residents, over 3/4 of our sample, said they did routinely before COVID-19. During the pandemic, which of course we're still struggling with, almost 60% say they never go outside. And this is something that a lot of nursing homes have been trying to address, and I hope to hear more from you on that during Q&A. Next slide. A well-organized nursing home can be a really busy place with group activities going on in various parts of the building at different times of day. That has changed dramatically during COVID-19. And while I personally haven't been in a nursing home in the last year, I'm imagining many have not felt that they could schedule group activities of any kind. And this sense of non-activity can be very problematic. And the desire of residents not to be mainly confined to their rooms is quite clear. Here, 59% of residents, of participants who responded, reported participating in activities 3 or more times a week before the pandemic, but after COVID hit, 54% reported participating in no activities. Next slide. This slide shows the dramatic shift of residents no longer dining together, even socially distanced, but rather eating in their rooms. Next slide. So what are the remedies to these rather extreme circumstances? One effective way is to connect to the world and to loved ones virtually, which we're doing right now. But how wired are nursing homes? We set out to discover this in our survey. We asked residents whether they had access to Wi-Fi, and 67% said yes. We asked residents if they had access to their own computer or device, or could use one that the nursing home makes available, and 47% said yes. And finally, we asked if the nursing home tried to organize participation in online activities, like a concert, a book club, an exercise class. And here the answer was either no, 45%, or I don't know, 28%. So one conclusion that we could draw from that is that if nursing homes focus on programming more, of which there is an astonishing amount available online these days, I think that would be beneficial. And I'm pretty sure that some of you are already doing that. Next slide, please. So given how infectious and lethal COVID-19 is for our frail elders, we thought it was really important to understand how safe residents feel. Here you can see that 1/3 of respondents say they have no concern, close to half are somewhat concerned, and 1/5 are extremely concerned. This range may suggest that it's a good idea to ask residents directly how comfortable they are or they aren't engaging in social activities that involve any level of risk due to personal interaction. Next slide. However, when it comes to staff, residents by definition, of course, need to interact extremely closely with direct care workers and nurses and other providers. So we asked residents for their observations about the use of PPE among staff. And here we see that residents reported seeing staff wear PPE most of the time, 78%. That's good, but there's room for improvement. And we know that PPE, as I mentioned earlier, was not initially prioritized in nursing homes. And I think that some nursing homes still have trouble getting it. Nursing homes have been treated quite differently in that regard from hospitals, despite caring for an equally fragile and frail population day in and day out. That's one of the things that we should work to change permanently going forward. We also see that staffing, a perennial problem in the long-term care residential sector, remains what I would call a significant problem in the pandemic, with half of respondents saying that despite increased work needs, there are fewer staff available to provide care. That's a big discussion and hopefully something that policymakers will take up, and I'll talk a little bit more about that later. Next slide. So here we get to resident voices. What are they really experiencing? And this slide and the next one comes from the open-ended survey question, where residents could tell us how they felt in their own words. And as you can see, they feel pretty terrible, and it's not because they're afraid of the virus, it's because they feel helpless and abandoned. The word prison comes up in many of the comments, and a deep longing for the touch of those who are dear to them. Next slide. And here are some more responses. Residents feel as though they have little to live for, which can manifest in loss of appetite, acceleration of dementia, and even premature mortality. Residents are well aware that they have very little time left and they don't want to be shut away for the last years and months of their life and cut off from those who are most important to them. It's the little things like getting your hair done that can sometimes really matter. All right, next slide. So what can we do about all of this? We really wanted to include in our report, which we can send you a link to. I could put it in the chat later on. We want to include a bunch of things that we heard from other people, that we found in the literature, about what can be done to address social isolation and loneliness. And here's what we learned from residents about what can be done. Basically, they want regular access to communication technology. They want to be able to go outside. They want opportunities to see their families before the last few hours of life. And they really want to be asked, you know, what activities and what interactions they most desire. So one way to think about this is that we can gather resident and family input on activities and use that to connect and maintain activities that residents really want to undertake and that are safe during COVID-19. And one of the ways that you can actually plug this in is through QAPI, the Quality Assurance and Performance Improvement Project, the performance improvement projects I'll talk about in a minute. Okay, next slide. Okay, when it comes to improvements, one of the most important things that we can do as well is to support staff more. Staff really are doing a heroic job during this time. They need extra support. So there are a list of ideas here: staffing flexibility, sick pay, hazard pay, simple recognition of their very hard work, perhaps providing daily meals for them, rest breaks, if it's possible to provide housing on site. That would really improve staff stability if it's possible to do any of that. Another thing that can be done is to use staff more flexibly. So for example, you can think about assigning department heads and other administrative staff to be more available perhaps than they normally would be to talk to families by phone who are very, very worried about their elders, and to update them on a continuous basis. Training, which we talked about a little earlier and did a poll on, is very important at this time to focus on reducing the risk of resident isolation, to show staff how to use PPE properly, to reinforce infection control protocols, and to help with end-of-life care. Instant communication is great. So WhatsApp groups and other things like that can be very useful in an environment which is moving very quickly and where, you know, cohorts are being formed, people's possessions are being moved, and so on. In general, I have a friend who is working in a nursing home, and she's actually an activity director, and she's doing an awful lot of help, things to help other staff. For example, she sets out meals for people if they need to eat in their rooms, things that she doesn't normally do, and she's happy to do it. So that flexibility is really key. Next slide. And here on the public policy front, there's a lot that can be done. These are a few ideas. Long-term care ombudsmen are now back in nursing homes, which is terrific. They do have the ability to receive complaints about social isolation. There are codes for that, and we hope to be able to actually look at that data and follow it to see if there is continuing social isolation, which our poll indicated it's still a problem. So policymakers need to see that, and they need to think about it as to what the best responses are from a policy perspective. I think one of them would be to roll the risk of social isolation into care planning at the beginning, and to pay much closer attention to it. CMS, of course, could be directed or could volunteer to publish best practice analyses of nursing homes that are really taking this very seriously and doing a great job at countering social isolation and loneliness. I think that would be terrific. And I know that best practices are being developed every day. And CMS could actually push that out to policymakers on a regular basis. so that it informs the policy that they are going to be taking up, which I think they will, as much as possible. I think the Finance Committee, the House Ways and Means Committee will all be looking at nursing homes quite closely in the 117th Congress. Okay, next slide. All right, so now I'll get into something that I think is another route to take action to address social isolation and loneliness, and that's comprehensive culture change. At its heart, culture change is about staff training and adjustment of daily care routines to infuse person-centeredness. Building relationships with residents is not only entirely possible, it's really rewarding for staff. And it does mean taking more time, however, to get to know residents, checking their preferences, understanding their unique qualities. And like any relationship, that does take time. On the care side, it means making a myriad of shifts in routines. And that's what the training and mentoring is really all about. So given the circumstances of COVID-19 and everything we've been talking about, culture change may seem like an uphill climb, but as we will see in a minute, there's strong interest in pursuing it actually because of COVID-19. All right, next slide. So we've been doing culture change work in Michigan, and this is how we've organized a project, and it's continued and actually thrived during COVID-19. And we're hoping to take this kind of approach to other states later this year. Basically what we do is we recruit homes, we work with a training partner, that can be Eden. We hope to work with the Greenhouse Project or another very high quality training organization. And we work with homes over a pretty extended period of 3 years. And the reason is that that's enough time to see if culture change really can start to take hold. And as you see on this slide, our assessment of the impact is designed to be as comprehensive as the training process itself. We look at some clinical quality metrics, the specifics of how practices and protocols change over time, how residents and staff perceive the gains being made, and what the measurable financial impact looks like. Next slide. An important note here is that we don't recruit just 4- and 5-star homes. We're open to homes at varying stages of performance and quality. We basically meet them where they are. And although we haven't yet worked with a 1-star home, we might be able to do that if they were sufficiently motivated. We've recruited one in a state in which we're currently applying, in fact, so look forward to that challenge when it comes. Next slide. Next, there we go, okay. So here's a bit more about how we organize the comprehensive culture change work that we do. The program is funded with the pool of funds that states have from civil monetary penalties when nursing homes are assessed for deficiencies. As a quick footnote, a little bit more than a decade ago, when I was a staffer working for the Senate Aging Committee, I noticed that CMP funds that were levied under federal law were not flowing back to nursing homes. They were going back into the Treasury and being used for a variety of purposes. And when I realized this, after doing some research, I decided that the funds would be better used if they could be used for quality improvement. So we did that in federal law, and that has supported, I think, some good research, and probably some of you are funded through CMP funding. Okay, next slide. So here's how we measure and assess the impact of comprehensive culture change. And this is one of my favorite slides because it's kind of a 30,000-foot view of the quality improvement work that we do. First of all, we track these quality metrics from the MDS and from hospitalization data that homes submit to CMS anyway. We have Google Sheets that are easy to fill out, and we basically get the data a little bit earlier, about 6 months earlier than it would be posted on CMS's website. So it's more useful for tracking whether there's any correlation between the culture change training that homes are getting and these metrics of depression, antipsychotic use, ADL dependence, and hospitalizations. We design our project in a non-inferiority construct for this purpose, meaning we don't expect the clinical quality measures to necessarily get better, but we don't expect to see a worsening. That's our hypothesis. Of course, we would hope that the clinical quality would actually improve. And we really wanted to spend a good amount of time helping staff to track what they are doing and effectively to analyze it more deeply in order to see whether the changes in care practices and protocols that are more resident-centered are actually happening. So we looked at the literature and existing tools, and we decided to combine them, if you will, into what we call the systems change tracking tool. It's an online tool, very easy to use, and a group of internal culture change leaders, a cross-section of staff who are really interested in and involved in culture change, meet quarterly to fill this tool out. And it's based on the literature and arrayed in 6 domains. That's the Hatch model framework. And those 6 domains are care practices, workplace practices, environment, family and community, leadership, and stakeholders. So the tool has a scale, and staff self-rate their practices on that scale of 1 to 4. 1 means there's no plan to try to achieve progress in that area yet. 2 means there is a plan. 3 means the plan is partly implemented, and 4 means the plan has been fully implemented. An example of a question or area in the workplace practices domain is the home has a process in place for staff to problem solve together and to share best practices. And an example of a question in the care practices domain is residents choose when to bathe. There's also a resident version of the systems change tracking tool that we are getting ready to pilot, and it's shorter, basically a subset of the systems change tracking tool. We buttress our examination of the impact of culture change training in our projects with resident and family interviews as well, and staff interviews. And finally, we look at certain financial indicators, operational costs that homes agree are connected to culture change, say opening a new cafe or removing a nurse's station from the main part of the home, buying tablets for residents, and the impact on staffing and tenure and turnover, as well as occupancy. So it's a very thorough assessment. Next slide. Now we get to sustaining change. That's always something that researchers and funders who are doing and helping to pay for QI work want to know a lot about. So we do teach back webinars, and in the future we'll be doing learning collaboratives, and we assist homes with learning new skills, such as, for example, how to use their clinical data in process control charts, which look at trend data, and whether changes in, say, antipsychotic utilization are moving in a statistically meaningful way. And for quality of life, however, we really want to get homes to use the data that they're already collecting through the systems change tracking tool that I explained a minute ago. So for that, we look to QAPI, the Quality Assurance and Performance Improvement construct, so that we can use the data for that. And here we have a Michigan home that has decided to use the systems change tracking tool in that particular area. Residents have opportunities to engage in activities that promote relationship building to create an actual QAPI performance improvement project. So that's pretty exciting. Next slide. This is basically a quick overview of ways that it's possible to involve residents in a performance improvement project, and that's what the home in Michigan has done. They decided to survey their residents, and in that way, they got resident input into group activities that the residents really wanted to engage in. Those resident preferences were then integrated into the monthly activities calendar. Next slide. So COVID-19 is still with us, and the activities that residents said they wanted, that you can see here in this slide, reflect that we have to still be very careful and very safe. Residents do want to dine together, which can be arranged with effort at the doors of their room, which is what this home is doing, and perhaps in shifts. They're going to try shifts to keep a safe distance. Residents are very interested in celebrating holidays. That means food-related activities for them. That's what they want to do. Residents in this home are dog lovers, and they want to see many more at the window. And once the weather warms up, they want to go outside and see the dogs in person. And they really love music, so they want concerts. They also want help with their own personal devices to find what they're interested in online. And if they don't have a device, they would like the home to be able to provide them one or lend them a tablet. Okay, next slide. So this kind of work is aimed at really getting to what matters. And this is a quote from the survey from one resident who was particularly articulate. And basically I'll read it out loud because I just think it's particularly wonderful. I want visitors to be able to come inside to see me. I don't want to be restricted to my room all day and night. I want decent food and to have access to it. I want to be able to walk outside of my room and see my family and friends that I would usually see daily. I want to regain my strength, better quality of life, and independence. I want to be informed regularly about what the facility is doing and what is going to happen. I want to have my rights restored, and I want to have the freedom to come and go like everyone else. Next slide. So I think that we can accomplish this as we learn more about the importance of social connectedness, and I'm deeply grateful that the Greenhouse Project and IN2L are focusing on that. One way to plug in all the lessons that we've been talking about and many more that you are learning is to really advocate on behalf of comprehensive culture change, for which there is sitting in federal law an authorization to do a national demonstration on culture change in nursing homes. We wrote that into the Affordable Care Act 11 years ago now, and CMS really is interested in culture change. They have talked about it, but they haven't really sort of taken it forward and made it central to the standard of care in nursing homes, and we think there is the potential to do that. All right, next slide. So that's it from me. I think that we have much to do. It's been a pretty dreadful 2020, but 2021, we have a vaccine coming and things are going to change. And I very much look forward to hearing more about what you're doing and working together with you. Thanks so much.
And that was tremendous. Thank you so much. I, for one, learned a lot, and I actually took a few notes. I'm going to encourage people to, if you've got questions, to put them in the Q&A box, and then I will invite Marla DeVries to join us for a Q&A. But just a couple comments on what you talked about. First of all, I mean, I'm not really surprised, but banning family did not reduce harm. So in our quest to keep elders safe, I think our knee-jerk reaction is always, let's go to lockdown and let's prevent all the coming and going. And while there's something about that that might make sense, in reality, it did not reduce harm, and in fact, probably created more problems, as some of your research would indicate. So a question that I have for you, I know that there was an article written, I think it was featured in the Washington Post, about looking at family members as essential care partners, and that the virus doesn't know whether it's a caregiver or a family member in which that virus is residing. So could we not have family members be considered essential care partners on kind of a, I mean, I'm not saying so every family member could be one, but would there be some strategies that we could employ if the positivity rate was low, if we put PPE on family members, if we were doing testing on family members? Could we have family members come and go? And is that a realistic possibility?
I think that it is, yes, and I think it's important. I think that these discussions should be had with CMS and with state officials, and we should go and talk to them as much as we can. The positivity rate is still quite high. I see a note here in the chat about how one county, Gene Urban says, has a positivity rate of 26%, which is pretty terrible. So it's going to be a conversation that will probably take a while to play out. But I think what we know, from this survey and from the literature and from other work, is that long-term social isolation is extremely harmful. It does contribute, to morbidity and to premature mortality. And the excess death question is a very serious one. So taking definitive steps to address that is quite important. And as we know, CMS did change its policy in mid-September. And yet I'm not sure that, particularly given the poll that was done today, that the change on the ground has happened the way we'd like to see it. So that tells me that we have more work to do and many more conversations to have.
I think probably as a follow-up to that is, where is elder autonomy, choice, human rights? Where is that in the equation? And their ability to be able to be a decision maker or to be involved in the decision-making process. And I know I saw the word inhumane in one of your slides. And when I think about the inhumanity, that we have done with elders. I mean, coming from a good place and wanting to keep people safe, but we really have, it appears to have deprived them of choice and their ability to be involved in decision making. So any comments about that and any strategies from your perspective that we could take to make a difference?
It seems as though a lot of elders agree with that, at least those who participated in our survey, and they're not happy to not have been consulted and asked, really about their tolerance for risk. And there is a way, to do that. You can have negotiated risk, essentially, which is where you basically have conversations and agreements that even though something may not be as safe as a particular individual in a nursing home who's working there might wish, if a resident agrees that they really want to do that, then you can form an agreement to allow it, to permit it. It does happen. It should happen more. It should be a more common practice, and perhaps a little work on thinking that through more and standardizing it a little bit would be helpful. I think that's the sort of discussion that CMS would probably be open to, and state officials would be as well. People have different tolerances for risk, different desires, and that needs to be taken into account.
Well, that's the individuality of each human that is living in a nursing home. So I'm going to invite Marla to the table just to see what questions might have come in, and otherwise I'll keep going.
So a few did come in, and it's kind of, there's some related to your study, and then some related to really what you talked about at the end regarding the different CMP projects. So how large was your study, your survey study?
It ended up being 365 residents who responded from 36 states. And that's a modest size survey. It's a survey of convenience. So people who found it and decided they wanted to respond did. It's not a formal survey in that sense. We'd love to figure out how to do it again. We did this with internal funding, and we could do it again. We could try to make it larger. So if anybody's interested, give me a shout.
All right. And along with that, I think people would like your email address displayed. So I don't know if Janet, maybe if you can put that back in the chat box. There's been a request for that. So here's one about the role of volunteers via virtual technology. So really when you talk about, you said there's kind of a plethora of programming out there, as well as to be mealtime conversational partners with residents who can't otherwise be near their cohorts in the nursing facility. So any thoughts on what you've seen, what you've heard, what you think about that?
Well, I love the idea of volunteers and people in the community reaching out to nursing homes. I think that's fantastic. And actually we're involved in another project, and it's called the Community Care Corps. It's actually run by the Administration for Community Living, and we're in the first year of the program, and we did get funding with 3 other organizations to continue it. And this is in Michigan, so Washtenaw County Jewish Family Services is doing virtual outreach to elders in the community. I don't know whether any of them are nursing home residents, but it makes a big difference, is what we're already finding. So you can't go in physically, but you can develop friendships and relationships and get close to people, in a virtual format, and that's what they're doing. So it really is friendship, that can be offered pretty easily online. So I bet there are best practices out there and other examples of this, and we'd love to know more about them so that we can do more of it.
Nice. Well, and there was a comment that came in through the chat that said, virtual is great, but what about people with visual impairments? So, the comment was, we can see him, but he can't see us. So yes. Any thoughts on that?
That's a harder one. I guess I don't have any immediate answers to that. Yes, I mean, by the time, you're having people in masks or other more sort of concealing PPE. If you're trying to talk through a window and the window isn't very, transparent or easy to see through, all of these things are barriers. And so I don't know that there are sort of easy answers to that. I think we do have to kind of get past some of the epidemic stage as quickly as possible, with vaccination, obviously, for healthcare workers and nursing home residents first up, albeit not as quick to be distributed as we would like. But I don't have any quick answers for that one.
Just a real quick comment. I know one of our communities, greenhouse communities in Longmont, Colorado, did a virtual hug tent. And it was really wonderful the way that it was designed by someone in the community. But the expression on the elder's face, and he said it just felt so good to touch her. I mean, it was through plastic sleeves and the whole bit. They went to great lengths because, to the point of, we crave human touch. And I think, technology is wonderful. And kudos to IN2L and all the other technology folks that have done amazing things. And to our providers who have really ensured that they had the Wi-Fi, that they had the ability to utilize those devices. But I think, we have to think about some of that, the real stuff too.
So there are a few questions related to your CMP project. So one, just clarification about where you work. So you don't work just in Michigan.
No, we would love to work all over the country. And I think perhaps not all states, but almost all states do have CMP funding. And so it is available, to be applied for under somewhat different conditions depending on the state. But we have applied in Ohio and Kentucky, as well as Tennessee. So we would hope to take this elsewhere. And the idea is that if you build up a consistent and robust body of evidence of where the changes actually can be tracked and captured and analyzed, that this will make it much easier to, at the national level, make a robust case for making these the standards that can and should apply, or guidelines, best practices, et cetera. And that is the hope and the promise of the kind of work that we're trying to do.
Nice, exciting. Can anyone have access to this systems change tracking tool?
Yes, absolutely. I will find a link and send it. Can we send it to all the attendees afterwards? Is that possible? Okay, I will do that. Yes.
And then along with that, the way I understand it is that it was created really for nursing homes. So do you see the applicability like into assisted living and other settings?
Yes, absolutely. It's a pretty simple tool in the sense that it's organized into those 6 domains, and it's a bunch of questions and has the scale of 1 through 4. It would apply to any congregate setting where people are living and receiving care. And I think it's most useful when you use it over time and you can see where the needle is moving or where it's not moving. COVID-19 obviously put lots of people back in terms of what they were able to accomplish, and that shows up. And if you are honest about it, as a group of staff, then you can see where you're making progress and where you're not, and then you can basically take action. So it's available to anybody that wants to use it. It'd be nice if we knew if you were using it and you would send us your results. Then we would reflect those forward.
Well, and you gave a great segue because there's a couple questions related to, so one is how are staff responding to the changes? And then 2, was it challenging to get administration on board?
One of the keys, as you all know really well, to successful culture change implementation and sustaining it is leadership. So you do need to work really hard with the administrators, with if there is, a board, involved in a chain or something like that, they need to hear about culture change. They need to buy into it. They need to want to do it. And increasingly, as we're applying in other states, for example, we are talking to people in the corporate suites, you know, as well as individual nursing home administrators. So that's essential. What was the first part of the question? Remind me.
How are staff buying in?
Oh, yes. Staff.
Yes, sorry, I put myself
Right.
on mute. Yes.
So frontline staff, I would say appreciate, you know, the goals of culture change. Sometimes they find it challenging to move from a task-oriented way of doing their work to something that is more relationship-centered, much more relationship-centered, and to try to take into account individual preferences. So the amount of staffing and the training of staffing so that they feel that they can do this is important for success to really take hold. Like anything, you know, it takes a while for people to fully internalize, you know, once they get the training, what this really means and what they have the authority and the power to do to change. And that goes back to leadership. Leadership has to allow that and encourage it and incentivize it. So I would say that's why culture change really needs to be facility-wide, you know, needs to be throughout the nursing home for it to actually not revert to the mean, essentially.
You know, thank you, Marla, for your help. I just interviewed somebody for our podcast, Elevate Elder Care, and he talked about the role, in this case, it was Eden Alternative Education, what it did in really equipping his staff for the pandemic. He said they had done the education and what the staff was able to do to really step in and be almost surrogate family members. But they really had bought into that idea of how important relationships are. And that's really what you want. But to your point, it takes leadership that really fully buys in and makes it a system-wide and organization-wide initiative. And the work that you have done in this research, the work that you are doing with the CMP grants in Michigan and hopefully other states, we'd love to see you come to Maryland as well and other places across the country. And we really hope that we can work more with you. But thank you for your presentation. Thank you so much for the work that you do. We will make sure that this presentation goes out to everybody along with Anne's contact information. And if there are other resources that you want to provide for us to send out in this packet, please send them our direction. We'll make sure they go out.
I'd be delighted.
Wonderful. Well, thank you once again. And I'm going to just ask Janet to go to our slides to let you know, give you a peek into what's coming up. As I mentioned, this will be a 6-part series. And we just scratched the surface, and we really wanted to start with Anne and her research, really set it up to let you know just how incredibly challenging this time has been. So Janet, if you go to that next slide, on our next one, and that'll be 2 weeks from today, we're going to hear from Dr. Emi Kyoda. She is the founder of Ibasho. If you don't know what Ibasho is, you will certainly want to be here to hear a little bit about Ibasho, Emi's innovation that has played out in Japan, has played out in Nepal, has played out in the Philippines. And here she is an environmental gerontologist, and you'll hear from her perspective the role that design has in promoting social connectedness. On the next slide, you will hear from Jack York and gang at IN2L. You know, Anne talked a lot about technology and how important technology was to making those connections. And we do believe that technology has played a vital role during this time. So let's hear from Jack's colleague, Karen O'Hearn at IN2L, and she will share a little bit about the experience of IN2L. After that, I know we don't have a slide on this yet, but we'll be talking with Dr. Al Power on the dignity of risk and really balancing upside downside risk and what that looks like. In our 5th session, we're going to be hearing from those who have actually have stories to share from their experiences and where they got creative in really implementing person-centered and person connections through the pandemic. So I do hope that you'll join us. Elevate Elder Care is the Greenhouse Project's podcast, and a new episode airs every Wednesday, so you'll want to make sure that you subscribe on Apple or Spotify or Stitcher, wherever you listen to podcasts. And on Friday, Marla DeVries and Mary Hoffner Thomas, my colleagues here, will do a recap of each Wednesday episode. So these are the ways that we are going beyond better. I challenge you to go beyond better, to take something you heard today and make application and go make a difference immediately. This is the year that we go beyond better. Thank you everyone for joining, and look forward to seeing you in a couple weeks. Take care, have a great week, be safe, be well. Bye-bye, Ann.